It is a great pleasure to welcome again everyone, and particularly our international board and the speakers who agreed to present the case here for a hopefully interesting discussion. For everyone who is interested more specifically in the cases, you have the possibility to log into the forum of the Sarcoma Academy, and there you can study the cases in detail. In the future, you will also be able to share cases there for discussion, and I think that will be an exciting opportunity to further enhance our international collaboration. Without spending more time, I would like to introduce the first speaker. This is Jean-Jacques Stelmes. He is a radiation oncologist in the south of Switzerland, and he will present a case that we all share together. And it is, let's say, the assumption that Jean-Jacques will present also the questions. And in the end, after 10 minutes of discussion, we have Axel and Jean-Yves who will comment on the case. And with all of you who present your questions and just bring in your own specific questions, and so we can address them all together and address the cases. So having said that, please, Jean-Jacques, start with your case.
Okay, so thank you very much for giving me the opportunity to present my case inside the Swiss Sarcoma network. So it concerns a young lady of age of 37 years, female. She notified a slow-growing lesion at the level of right upper leg, at the level of the thigh, which was growing since 6 to 12 months. Otherwise, she had no other comorbidities. She was a good health status. She was a light smoker, but otherwise, she had no other risk factors. So she decided to consult her local surgeon, which was near to her village where she lives. And so the surgeon decided to proceed with a surgical resection under local anesthesia. And during the intervention, he notified that the tumor was quite crumbly and quite friable, and was difficult to access, and also under local anesthesia, so it was quite painful for the patient, that he decided to interrupt the procedure, and he sent the patient to our hospital. So this procedure was complicated by a significant postoperative hematoma around the surgical scar, as you can see. This picture was taken 2 days after the whoops resection. And on the right, you see the picture which was taken 1 month after the intervention. So the hematoma was reabsorbed. So we decided to make an MRI. As you can see here, there's a lesion of about 51 millimeters in the longitudinal axis. You can see the surgical cavity with the remaining tumor. And on the right side, on the axial picture, you can see that it seems that there is a co-involvement of the sartorius muscle. So the definitive anatomopathological report describes a soft tissue lesion with a diffuse enforcement by a plump epithelioid solid proliferation, medium-sized, mitotically active malignant cells of about 9 to 10 mitosis per field, absence of gene fusion on the ARCA fusion panel, with a mutation of Notch1 pole and MDM4 genes on oncomine. And yes, on immunochemohistochemistry, you have a co-expression of CD34 and PAN-CK with loss of nuclear expression of INI1. Ki-67 is of 20%. So this pathological report was counter-reviewed by a sarcoma anatomopathologist. And the final diagnosis was an epithelioid sarcoma of proximal type. So my first question to the public and to the board is, which treatment do you recommend after this whoops resection complicated by a postoperative hematoma in this young lady? Do you go for resection with white margins and plus lymphadenectomy? Do you go for neoadjuvant treatment options with chemo followed by surgery, or chemo with hyperthermia followed by surgery, or radiation plus hyperthermia followed by surgery, or only neoadjuvant radiation therapy?
Yes, so we have 37% on immediate surgery with white margins, 15% on neoadjuvant chemotherapy followed by surgery, 5% neoadjuvant concomitant chemotherapy plus hypothermia plus surgery, 14% on neoadjuvant concomitant radiotherapy plus hypothermia plus surgery, and 27% on the neoadjuvant radiotherapy.
Okay, thank you. I couldn't hear the first immediate surgery with white margins. How many percent?
41%.
41%.
41. So this it's the first answer. It's the okay. So I think there is no absolute answer, but we can discuss this maybe at the end, or if we can discuss this also now. What we did also after discussion with inside the board.
I cannot see the slides. Good.
You can see my slide?
Yes, yeah. Please go on.
Okay, I can see. Okay, so yes, what we decide inside our tumor board was to go for radiation therapy in this case, added to hyperthermia. So as you know, maybe in Switzerland, hyperthermia is reimbursed for high-risk sarcoma patients, and so we added this treatment to the radiation therapy. We did a conventional fractionation of 50 gray in 2 gray per fraction, including also the upper part of the inguina, and with 1 session per week of hyperthermia. Okay, so maybe we can discuss this at the end. I will follow with my second question. Does the postoperative hematoma actually affect your local strategy? Or no, it's a similar procedure as with every whoops resection, so we resection? Or do you proceed, do you change your strategy, your local approach? Do you resect maybe a bigger area, taking into account the hematoma? Or yes, was this actually the reason also for local neoadjuvant treatment?
So there's no procedure, 18%. Resection of the entire contaminated area, 45%. And yes, reason for neoadjuvant radiotherapy, 36%.
Okay, so it's 1/3, 1/3, 1/3. Is this correct? Maybe more or less?
More or less, yeah.
Okay, so I see that it's not clear.
Please show the slides again.
Yes, so I will continue. And yes, I will follow immediately with my last question, which is a more provocative question, as it's not quite my field. So the patient did now the radiation therapy, and I think that she will be operated very soon. So let's say, based on the histology, let's imagine that this patient will recur in near future or distant future, distally or maybe also locally, but if locally and it is not amenable for surgery, what would be the choice of a systemic treatment? Would it be gemcitabine based, anthracycline, pazopanib, or a target therapy, tazemetostat?
So gemcitabine 6%, anthracycline based 38%, pazopanib 31%, and tazemetostat 25%.
45%. Okay, that's good.
25%.
25. Okay. Okay, so that was my last slide.
Thank you very much, Jean-Jacques. Well, maybe we address the questions to Jean-Yves and Axel. What are your comments on this?
Wow, that's a typical whoops patient, and that's complicated, as you rightly point out, with the question of the hematoma, which should be considered as contaminated, as you rightly point out. I think it's really difficult to say what to propose. We of course, tazemetostat. I start by your last question, actually. Tazemetostat is a very well tolerated agent, a good biological rationale, good results in single agent first line untreated patients, but we don't know what will be the future, of course. Doxorubicin ifosfamide, well documented, activity modest, but some patient with really an outstanding activity in this proximal epithelioid sarcoma. Sometimes that happens. I mean, as in all sarcoma subtypes. So what to do after first whoops operation? I'm not so sure. We would have discussed probably neoadjuvant chemotherapy. Probably would have gone for immediate surgery. Actually, what this points out is that we should receive this patient after a biopsy and not after a whoops, and that would be easier. Axel.
What do you have proposed, Jean-Jacques? It is exactly what we propose here for this kind of epithelioid sarcoma, whoop surgery. It is you mentioned that it was a slowdown, progressive increase, so this is not an explosion of the tumor before the first surgery. Chi 67, only 20%. Maybe it was a superficial sarcoma secondary with an invasion of Sartorius, maybe due to the surgery, but I have not seen the first MRI of the first before whoops, so but it seems superficial and secondary with involvement of the fascia and maybe Sartorius. Tumor less than 5%, tumor less than 5 centimeters, so it's a T1. So this patient needs radiation therapy, so it's better to propose induction radiation therapy than after radiation therapy. So it's typically the case where we propose also induction radiation therapy first, radical surgery, of course, and then no adjuvant chemotherapy because it's a T1. epithelioid sarcoma is not so chemosensitive sarcoma. And in case of relapse, I'll be in favor of first line tazemetostat will give excellent results in front line. So we have to move our paradigm in epithelioid sarcoma. We have to need a new agent, more epithelial approach than sarcoma. Doxo-EFO is not very active, so sometimes we use combination of platinum, like an epithelioid carcinoma, like gemcitabine platinum, navetabine platinum. There is some response also with this old drug, but not for sarcoma subtype. So I propose exactly the same schedule like you for treating this patient.
What's the usual approach in your centers regarding surgery, this hematoma? I mean, there are surgeons who just scotomize and don't, just neglect the hematoma, which is, let's say, potential spread of the tumor cells, and maybe specifically with the epithelioid sarcoma. How do you address that?
There is little doubt that all the hematoma is contaminated potentially. I think that's a R2 surgery at best. So we should consider the hematoma as being contaminated. So in a sense, that pushes you towards a surgery which is very different from a classical whoops.
Yeah, I'm very happy about this statement. I think that's very important. Are there any other urgent questions? I think for the sake of the time, it's 20 past. I think we have to move to the next case. Manish Dr. Agarwal from Mumbai, he presents the next case for us. Please, Manish.
Thank you, Bruno, and thank you very much for this opportunity, and a big hello to everybody seeing this presentation. I'm from Mumbai, India, as Bruno said, and this patient actually, which I'm going to talk to you about, has come to us from our northeast, which is a very ill-developed state for medical facilities. So with that in context, I'm just going to show you the details of this case. This was a 56-year-old lady who was a well-controlled diabetic. She's had shoulder pain for 4 months, and her local doctor got her x-rays done, which shows a nice big lytic lesion in the proximal humerus. They did a core biopsy, which just showed some hemangiomatous fibrofatty tissue. I don't know how much to rely on this report because the local pathologists don't have much experience with sarcomas. But the CT thorax showed just a hypodense thyroid nodule, and the FNAC of that thyroid nodule was negative for any tumor. There were no lung nodules. This was her MRI from that point of time. Again, in the area of the lytic lesion, one can see that there's a tumor occupying the humerus, but there is not much of a soft tissue mass here. Again, you can see on these axials is that there is a little bit of edema around, a little bit of breakthrough on the bone, but a very, very small soft tissue mass at this point of time. So the local surgeon actually curated this, assuming this to be something benign like a giant cell tumor. They filled in some bone substitutes, as you can see on this X-ray, and they put these crossed K wires. So this is something like a whoops for a bone resection. And the final histopathology report was a fibroblastic osteosarcoma. And this is the time when this patient got referred to us. When she came, those wires were actually pointing out of the skin. So we just removed the wires. Then we got these X-rays. As you can see, the disease seems to have progressed. There's a pathological fracture. Apart from the bone graft substitute here, you can see some dense sclerosis in the humeral head. And we reviewed the pathology slides, and our review of the pathology was again a moderately cellular epithelioid tumor with woven bone. So it was called as an osteosarcoma. We did a PET CT, and this was the only site of disease. This was the MRI after we removed the wires, and one can see that this has progressed quite rapidly. The soft tissue mass is now quite big. It's intra-articular. Our experience with trying to give chemotherapy, osteosarcoma chemotherapy for an older patient like this has not been very good. I mean, most of the time we have not been able to complete the chemo. We've had to reduce the dosage. And with this pathological fracture, this patient was in very severe pain. So we in our tumor board, we decided that we will just go ahead and first do the resection because we were not very convinced that this is an osteosarcoma, because this is an unusual presentation. And so we decided that we will go ahead and first do the resection, get final pathology. Here you can see the wire entry marks which were there. So we were able to resect it completely, and we put in our tumor prosthesis to reconstruct this. That's what the specimen looked like. We did an extra-articular resection, as you can see, with part of the glenoid into, so that we can get the whole tumor out. That's the post-op X-ray. We also excised those K-wire tracks, assuming them to be contaminated. And the final pathology was again an osteosarcoma, but with lots of hemangiopericytomatous areas. You can see on the IHC that's negative for the vascular markers. It's negative for EMA. So she was started on doxorubicin and cisplatin after we had a tumor board discussion. Again, as expected, she had very poor tolerance, and even after dose reduction, we had to discontinue the chemotherapy after 5 cycles. In September 2019, we did a CT scan as a part of the regular follow-up screening, and there were just few fibrocalcific opacities which were reported by the radiologist as likely to be sequelae of previous infection. In September 2020, which is a year later, she developed a swelling in the medial mid-arm area. And a local surgeon, again, assuming it to be a sebaceous cyst, actually excised it. So another whoops. And the histopathology this time was a cellular spindle cell lesion with lots of mitosis. This was the X-ray. Now, this was the time at which there was a lockdown everywhere and COVID was there. So they could not actually travel to Mumbai from the Northeast. So what she did was did an X-ray, sent it to us. They had a regional cancer center where they could do a PET CT. And the PET CT just showed a mild periprosthetic uptake of FDG. Again, a reactive or a post-operative uptake in the area where she had been operated. And the same tiny calcified nodules which was seen previously, they were not FDG avid. I couldn't get an MRI done because they didn't have any center which could do it with the Mars sequences there, so because there was a big prosthesis inside. So again, the question at this point of time, what do we do at this time? I mean, do we re-excise this contaminated bed from the superficial excision which has been done? Do we just observe her, or do we do a 4/4 amputation at this stage? So we actually just observed her because she was not able to come even for the surgery, and we couldn't really find any surgeon who could do the excision at that time, which I would have preferred. So in 3 months from her previous excision, she developed another recurrence at the same site. You can see this now. At this time, she was able to travel and come to us, so we were able to get her MRI done. And you can see that there is a well-defined superficial mass there on the same medial side of the mid-arm area. This looks very different from what she had in the bone. So this is the imaging from the area of the previous scar, which you can see there is some signal intensity changes, but there was absolutely no uptake of PET CT of FDG on PET CT in that area. Whereas the SUV max was 5 in the medial arm where we were seeing that lesion. So we decided to ignore this particular part. The lung nodules were exactly the same, and we said we excise this medial arm swelling at this time, and that's what you can see. That is what we did. We confirmed that the margins were negative, But pathology-wise, we were surprised. At this time, the pathology was an angiosarcoma, strongly positive for CD31, some CD34 around the vessels, and factor VIII was focally positive. We therefore reviewed the previous pathology because we saw that it had hemangiopericytomatous changes. It looked very vascular, but the previous pathology, our pathologist was very sure that it is still a bone-forming tumor and it was an osteosarcoma, and this he thinks was a separate pathology as an angiosarcoma. So again, now the question is, now that we know that there was a bone pathology, now there's a recurrence of a soft tissue pathology, which is an angiosarcoma, a high-grade angiosarcoma. How do we treat this? Do we treat this with chemotherapy, targeted therapy, or should we still think of doing an amputation? So another 4 months later, this time she has developed the same kind of mass, but on the lateral side. You can see the previous scar proximally. This has come below that scar of surgery. Completely different area from any previous surgery or contamination. There's nothing now on the medial side. The PET-CT shows the SUV max to be 6.5. And again, the lung nodules are exactly the same as what they were previously. So once again, we've gone ahead and excised this lateral side mass out. And you can see from this picture, this is at the end of the excision and the suture removal. And this again was a high-grade angiosarcoma with the pathology saying that this is less solid than before with more blood lakes. So again, the same questions is do you, with one recurrence on the medial side, one on the lateral side, what should be our best treatment? Chemotherapy, targeted therapy, or an amputation? Yeah, so we spoke to the patient about an amputation because we were now getting worried with knowing how angiosarcoma behaves. And we felt that before it is metastatic anywhere else, I think this was one chance to get rid of the disease, but she declined an amputation. So she came back to us another 3 months later with the arm looking like this. It was awful. There were multiple nodular subcutaneous lesions. As you know, we had the second wave of COVID between March and May. And that's the reason why she couldn't travel and come, and during which time this disease flared up like this. We did a PET-CT and found in June that she also had now disease in the bones. So we found disease in the scapula, in the tibia, but the nodular lesions in the lung were the same. This was the PET-CT appearance. You can see the picture. You can see the uptake in the tibia and in the scapula. Now I think it was futile to ask whether we should do an amputation. So I think the whole choice is now between chemotherapy and targeted therapy. Or should we still do an amputation is the question. So we actually did a tumor board and decided to put her on chemotherapy, which was gemcitabine, followed by gemcitabine and docetaxel. We gave her 3 cycles last on 24th August. And she seems to have responded somewhat. You can see that the lesions have become a little better than before. There were no new lesions really. And even the PET-CT is showing that very clearly there has been some response. So there is a partial response. Even in the tibial lesion, one can see that the FDG avidity is much less. So my question now to the experts and to everybody is that how do we treat this ahead?
Thank you so much, Manish. Maybe also here to Axel and Joy, what do we have to learn from this case? And then, of course, we have to answer the question that Manish rose.
It is an incredible case. It's a rare situation to have 2 histological subtypes to the same patient. I think angiosarcoma could be related to like Stewart Holmes angiosarcoma in the previous operate woman with a chronic lymphedema. It could be related to post-lymphedema due to the osteosarcoma, but in general, the interval free is longer than. So it's only 1 year between osteosarcoma and angiosarcoma.
Yes.
So it's a very rare situation, but I think could be related. Huh? So angiosarcoma.
Well, could this have been an angiosarcoma in the bone also?
No, you have reviewed the slide, so
yeah,
it's a rare situation to have an angiosarcoma of the shoulder.
Oh, yeah.
And it's multiple angiosarcoma on the right arm, subcutaneously. It's another disease like post-chronic lymphedema, like a Stewart-Holmes disease. So locally and relapse locally in other part, and then became metastatic. So after, of course, amputation is not an emergency in this situation. So after gemcitabine docetaxel, my advice is try to weekly Taxol, of course, pazopanib, oral navelbine, oral cyclophosphamide, monotherapy. Not useful to be aggressive with this kind of patient, not well tolerated the combination of doxo, cisplatin at the beginning. So Caelix also liposomal doxorubicin due to the previous course of doxorubicin. So sequential monotherapy over the time.
I would say two things. First, I agree with what Axel has been saying. It's very unusual to have two sarcoma in the same person at the same time. It's in the database from the French sarcoma group, we had 70 out of over 30,000 patients. So it's very unusual. So I would tend to consider it that these are probably two subclones which evolve differently. And it would be interesting, it would not be feasible maybe, but to compare the genomics of the two tumors, of the bone sarcoma and the angiosarcoma, to see whether they are subclonal, yes or no. Now, having said that, the clinical presentation is very unusual as well, possibly related to the whoops and operation also up front. The look of the X-ray at the beginning made me thought of undifferentiated pleomorphic sarcoma of the bone or an angiosarcoma actually. So anyway, you had the pathology review, it was an osteosarcoma, it may be a borderline tumor. The only comment I would say, but this is what you wanted to do, would be to use earlier four-quarter amputation, simply because even though it's unlikely to be curative, the only chance of cure may have been that at the time where she had the first relapse. But I understand that she refused that, which they do most of the time. Right now, I would. Well, the lesion is ulcerated at the skin, so it's not very good for VEGFR2 inhibitors such as pazopanib or regorafenib. So I think, given what she had received, I think the options are very, very limited. In the context of a clinical trial, if TLS would be observed, immunotherapy could be an option, angiosarcoma. But otherwise, probably I would start with VEGFR2 inhibitor, either pazopanib or regorafenib.
There was a question from the audience saying, well, can the bone formation in the first biopsy be secondary or as a response to whoop surgery?
Well, we had actually reviewed these slides even before the, I mean, from the surgery, but before the bone grafting, and that was also an osteosarcoma.
Very intriguing. Okay, well, if there are no further comments and questions, then we move on. Ralph, I don't see you. Are you among us? You are here.
I am on you.
That.
Well, everybody, it seems the webcam is. I have some problem to get a picture of me. I'm sorry. I see and get
but
everything.
We hear you.
Yeah. So, but otherwise, I'm hearing you pretty well, and that's, I think, that's the main part of the topic. Yes, I will present a 48-year-old patient with a high-grade myxofibrosarcoma of the left triceps muscle, who was quite a challenging case for our board, with a story in different steps. So the journey of the patient started in May 19 with a rapidly growing mass in the left triceps muscle, 5 to 6 to 7 centimeters. Biopsy revealed the G2 myxofibrosarcoma. You see a short excerpt of the MRI. So that's the first question for the audience. What would you do? Surgical resection, neoadjuvant chemotherapy, neoadjuvant radiotherapy, or both a neoadjuvant chemotherapy and radiotherapy? Okay. So what we did, we decided for a neoadjuvant radiotherapy, 25 to session of 2 gray, 50 gray, and then in September 19, the resection of the tumor where we radial and axillary nerve could be spared. That was September 19. Follow-up of the patient, and a bit of more of a year later, the follow-up MRI on November 20. Very suspicious for a recurrent, confirmed by biopsy, the same histology of the previously known myxofibrosarcoma. Again, here's the question: what should we do now? Neoadjuvant chemotherapy, because we didn't do before, so perhaps it's time now. Okay, it's already a recurrent, that will be a palliative situation, chemotherapy, but in a palliative intent. Still try to do again a neoadjuvant radiotherapy, or let's go for surgery first. We did again a neoadjuvant radiotherapy in a hyperfractionated mode with a total of 44 grades, and followed by the excision of what we consider to be a regional metastasis in the thoracic wall axilla room. That was done in March 21, the surgery, the resection of this regional recurrence. MRI 3.5 months later, that's the 6th of July, where there is a bigger lesion, which would attracted our attention first, but also 2 smaller lesions. So in a first run, we biopsied the bigger one, thinking, oh, that's again a recurrent, but no malignancy on biopsy. We reconsidered the imaging. Radiologists realized, oh, with a different MRI sequence, probably that's not a recurrence, but rather a postoperative hematoma, the bigger lesion, explaining the negative biopsy. But the contrast imaging on MRI of the smaller lesion are in opposition to the bigger one, very suspicious for recurrence, so biopsy again, but of the smaller lesion, which was confirmed to be a recurrent, this time Z3 myxofibrosarcoma. And with its revelation, a recurrent biopsy, we did an MRI again, and a bit more than a month later, with evidently a very rapid growth pattern of this recurrence. So second recurrence already of this nasty myxofibrosarcoma. So what would you do now? Perhaps it's time now for a neoadjuvant chemotherapy. I will still try to do some radiotherapy, but already twice the plexus is very close, so perhaps it would be better to use proton beam. Third option of this will recur anyway, so let's go for radical surgery and for 4-pattern amputation. And perhaps you think now, oh, that's a very tough case, I will refer the patient elsewhere. So please vote. We decided to go for neoadjuvant chemotherapy, and the patient was started on doxorubicin and ifosfamide, and this is running currently now. He just started the second cycle 2 days ago, tolerated the chemo very well. So we have to wait a bit more to know the response to this chemotherapy. We don't have a restaging on the chemotherapy yet, so the story is ongoing.
Yeah, it is a typical case of high-grade myxofibrosarcoma. Myxofibrosarcoma relapse more frequently than the other one. I totally agree with the proposition at the beginning. Which we will start also because it's a grade 2. We will start with induction radiation therapy, of course, before surgery. I have not seen the report of the surgery. The most important things for myxofibrosarcoma is the high quality of resection at the beginning and the first event. Large after induction radiation therapy to have a R0, but with a large margins. The patient relapse very rapidly, like myxofibrosarcoma. I think it's already maybe it's a grade 3 from the beginning because the interval 3 is very short. I'm impressed by the new induction radiation therapy because 50 plus 44 is 94 grays in this region. I have no experience of ray radiation field. We have to ask the radiation therapist community to collect this case because I have absolutely no experience to make two same schedule of induction radiation therapy on the same place. After, of course, at the end, we are more or less in the palliative situation. There is a large different nodule, so amputation is too late. We are in palliative situation, of course, and is doxorubicin containing chemotherapy regimen and so on.
So when do you indicate amputation in such a situation? I mean, would you have done that with the first recurrence?
No, that is, today the indication of amputation became less and less. More you have a rapid relapse like that, and more we have to avoid amputation because we have to consider this patient like morally like metastatic patient, an aggressive disease like that. If you make the amputation, 3 months later the patient develops metastasis. So we try to select the amputation when the patient have a local relapse 2 or 3 consecutive time over the time for a duration of maybe 10 years without any metastasis. I think it will be a good candidate for some synovial sarcoma relapsing every 5 years because we can cure the patient. But to propose an amputation 6 months later after the first well-conducted schedule, induction radiation therapy, large resection, the patient relapse 6 months later, we are in face of a very aggressive disease. And to make a salvage amputation, I'm not so in favor.
What type of chemotherapy options would you take into account? I mean, how long would you do this for how many cycles, and what other lines do you have available?
Myxofibrosarcoma is typically the histological subtypes where genomic analysis can be performed to try to find a target. Fibrosarcoma is very rare. It's not a very chemosensitive histotype. So after doxo, ifo, and gemcitabine or trabectedin or normal conventional agents, I think we are rapidly limited to propose, of course, pazopanib. But after that, I think to make a biopsy, you have a biopsy on one nodus, so we can make a genomic approach to try to have at least a target for an actionable target.
Very good. Any other comments? Ralph, Fatime, Manish? Then I suggest
very grateful to hear the input about rather not an amputation, because that was also a longer discussion in our board. Yeah, it's a tough case, so thank you so much for the input on this regarding this issue.
I'm not in favor of an amputation for this patient.
Yeah.
Well,
Very good.
I
Thanks
have
so much.
only one question, Bruno. One question
Please.
was why once the recurrence came and it looked like a small recurrence, it could have been excised surgically. Why was the radiation preferred again the second time to give preoperatively rather than do the surgery first? When there was a recurrence,
I think it was because the first recurrence was outside the radiation field, and that's why it was considered to be treated like a first
metastasis.
primary tumor. Yeah, that was the reason, and it was resected, right?
Yeah.
Further questions? Then we move on to Fatime. She's a medical oncologist in Basel, Switzerland, and we are looking forward to listening to your case.
I have chosen the case of a now 60-year-old patient who was diagnosed with myxoid liposarcoma in the left thigh in August 2010. Staging by CT showed locally advanced findings without evidence of distant metastasis. We decided at that time to perform an isolated lymph perfusion with melphalan and TNF. As a complication, the patient developed a compartment syndrome, which is why a resection had to be performed in November 2010. Adjuvant radiotherapy was then completed in February 2011. In 2011, the patient presented to the surgical colleagues for a regular follow-up. In April 2018, CT scan revealed a 10 by 6.9 centimeter ISO dense soft tissue mass with cystic portions in the right pelvis, extending into the obturator foramen with displacement of the prostata and urinary bladder and infiltration of the obturator internal muscle. We performed a CT-guided biopsy, histological. There was a metastasis of the known myxoid liposarcoma with focal transition into round cell parts. Almost 8 years after the initial diagnosis, we diagnosed the first relapse. We discussed the case in our tumor board and recommended a completion of the staging by CT scan. If no metastases were detectable, then combined radiochemotherapy with high-dose efosfamide was recommended in our tumor board. And PET scan performed in May showed a heterogeneous hypermetabolic tumor mass measuring approximately 10 by 8 centimeter as seen in the MRI. In addition, diffusely increased FDG activity was seen in the adjacent os pubis without clear morphological changes or cortical erosion, which was considered reactive. In August, we did the combined radiochemotherapy. It was completed in August. Here you can see the PET scan images before treatment beginning and after treatment beginning. After end of combined radiochemotherapy, here you can see the initial image, and here after treatment, it was described as a partial remission. Pre-operatively, we have done a MRI for the surgical planning, which revealed a new bone metastasis in the pelvic ring. So a whole body MRI was initiated. Here we saw a diffuse bone metastasis of the myxoid liposarcoma, with the exception of the right pelvic metastasis. All were rather small and non-threatening stability. No hepatic metastases were seen. In addition, we performed a skeletal scintigraphy, which showed a slightly increased bone metabolism of the known bony pelvic metastasis on the right side. The other bone metastasis described didn't show any increased bone metabolic activity. Since the local recurrence had been adequately treated and responded well after combined radiochemotherapy, we opted for a watch and wait strategy. In March 2019, we performed another MRI, whole body MRI in the follow-up, and saw two progressive locations, soft tissue nodule in the musculus quadratus lumborum and another one in the lumbar spine too. So we decided in this case to recommend a palliative radiotherapy of the two size progressive metastases. And a few weeks later, the patient was admitted with visual disturbance with double vision and visual field defects. The MRI of the head shows newly metastasis, intra-para and supracellular metastasis with infiltration of the orbit, elevation, probably also infiltration of the optic chiasm, infiltration of the cavernous sinus bilaterally, and infiltration of the pituitary gland. So a transnasal, transsphenoidal, microtechnical navigated guide tumor removal and chiasma decompression was performed, followed by palliative radiotherapy of this region. And the histology showed the pre-diagnosed myxoid liposarcoma. After the patient recovered, we decided to do this radioactive palliative radiotherapy. And just a second, sorry. And after recovering, I think 3 months later, we started the palliative systemic therapy with Yondelis. And in August, we've done really early restaging with whole body MRI, which showed a partial response. In December, the next whole body MRI, December 2020, the next whole body MRI showed a progressive disease of one lesion, which was located right para-iliacal. So we discussed this situation on our tumor board, and we decided to offer the patient a local treatment because it was a local progressive disease under treatment with Yondelis, and we would like to continue Yondelis and offer a local treatment. So we couldn't offer the patient a new radiation or a re-radiation because the dose was too high of the first irradiation. So we decided to do a metastasectomy. And in this we saw in the histology results, we saw that the node which was seen in the MRI as a progressive disease was completely necrotic, and the other node which was taken out showed a showed myxoid liposarcoma without round cells. In March this year, the problem was that the patient developed an infected lymphoceles, which was necessary to do an antibiotic treatment with augmentin. It was necessary to do it 3 times, and as well as a drainage. After recovering in May, then we restarted Yondelis. We are still continuing Yondelis. The last restaging was 2 days ago. The whole body MRI shows shows only avital bone metastasis, no lymphadenopathy, and the patient is doing really well. Here you can see a brief overview of the treatment since first diagnosis 2010, and actually with restarting of Yondelis. So I'm sorry I didn't prepare any slides for questions, but what I would like to discuss with you is what would be your recommendation in the situation we have had in January this year with the local progression. Would your recommendation will be as well a metastasectomy? That's the first question. And the second question is, would you continue with Yondelis until progressive disease, or would you pause until progression and then re-induce Yondelis? Thank you. Hello?
Yeah, you heard me?
Yeah, okay.
Very nice
Yes,
case.
so
Typical case of myxoid liposarcoma. There are a lot of message in this case. First of all, we have to follow for a long time myxoid liposarcoma because sometimes patient relapse after 10 years of follow-up. It is the first message. Second message, unusual localization of metastatic site. I remember to you that myxoid liposarcoma, the dissemination is sometimes more frequent outside the lung. So abdominal peritoneal cavity, pelvic area, brain, and so on. So it's typically a case of myxoid liposarcoma. The third message, the whole body MRI is a more accurate exams to follow the patients than PET scan, because you discover a little bone lesion in the vertebra and elsewhere more frequently than PET scan, because it's a low-grade soft tissue sarcoma histotype. So the uptake of FDG is a very some spots are positive, some other negative, but for all the metastases, the MRI whole body is very more accurate. And for your last question, yes, I totally in favor to be always aggressive. It's more like the GIST story, the myxoid liposarcoma. When you have some response, prolonged response with whatever agent, you mentioned Trabectedin, but also eribulin is very active in myxoid liposarcoma. With a drug without any toxicity, you can combine the drug to control maybe 90% of lesion, and when there is a partial resistance, when 1 or 2 nodules increase over the time, I totally agree to propose local regional treatment plus maintenance of a systemic regimen. Not only metastasectomy, but also stereotactic radiation therapy or radiofrequency ablation, to be aggressive in all different nodal progress over the time, and to maintain a systemic treatment. If the patient wants to stop and to make a wait and see vacation, we can do it, of course, with the patient, and we restart the treatment in case of overall progression. It's a case per case discussion we have to have with the patient, but we have to be aggressive with local original treatment for some resistance sites.
And now we are giving. I'm sorry.
Yeah, I would add that we have extensive discussion for whole body MRI in patients, in the monitoring of patients. No question that it's better, that's the best exam to look for mets in this disease. No question about that. But should we use it systematically to learn that there are plenty of mets that are asymptomatic? I'm not convinced. And there we have a debate with a colleague. So what we do is that we use whole body MRI only if we have decided to do local treatment for one or few metastases. In this case, it's really crucial because that tells you that you have to restart Trabectedin, as in your case, by the way, start and restart Trabectedin sometimes.
And maybe only if you have round cells at the beginning of the story of myxoid liposarcoma. If you have a typical myxoid liposarcoma without round cells, I'm not sure that the whole body MRI is useful. But if you have 5% or more than round cells, the risk of diminution is very high.
We are giving Yondelis at 80% dosage, and meanwhile at an interval of 4 weeks. And the first 2 weeks, the patient complains of pronounced fatigue, loss of appetite, and digestive problems. And the rest 2 weeks, he has a good quality of life. And we have discussed it many times with the patient. He will continue, but I see that it is getting worse and worse to continue. So that was my that was the reason of my question. What do you think about re-inducing when we see a progressive disease, or should I discuss again and again with the patient, please continue because it's better?
We have to be flexible. We have to be flexible with Trabectedin. So after 6 courses, the fatigue became more chronic, and the duration of fatigue between interval increased over the time. So I frequently increase the interval between each cycle. Sometimes for some patients, I give 6 weeks of interval to have. It is a case-per-case discussion with the patient. If you maintain dormancy situation with adapted schedule every 4 weeks, 5 weeks, 6 weeks, I'm convinced that in some patients is useful. It depends on the degree of anxious of the patient psychologically. Some patients want to continue on active treatment, some other I want to stop 3 months. But if you re-challenge after 3 months interval, the best way to restart an induction treatment every 3 weeks, and then after 2 or 4, in case of new tumor control, you immediately increase the intercycles between cure.
Yes, to be honest, it was a pause of 4 months after the metastasectomy because of the infection complication he developed, and we had a pause of 4.5 months, and we restarted in May this year. And at the beginning, the interval was 3 weeks. And after the first restaging, which showed stable disease, after that I did an interval of 4 weeks, and now I'm discussing with myself to prolong the interval. But when you say okay that it's a good strategy, then I will discuss it with the patient maybe every 5 weeks, or later every 6 weeks. Yes, that's a good idea. Thank you.
I think every 6 weeks. I don't recall any patients with more than 12 subsequent courses of Trabectedin who had received less than 4 weeks treatment. And I think the patient, my record of a number of courses of Yondelis, maybe over 60 for one patient, and he received indeed every 6 weeks and at a dose of 1,000 micrograms per meter square. So that's something really which needs to be taken into account in this case. Take your time. Maintenance, low dose spacing is something relevant.
Okay, thank you.
Well, what a lively discussion. That is a lot of fun. I would like to thank you, first of all, the 4 presenters who invested so much time and effort make such a nice presentation, which taught us a lot and gave us the opportunity to share. Of course, I would like to thank Axel and Jean-Yves. It's just wonderful that you share your vast experience with all of us. I think we all can only benefit. Last but not least, I also would like to thank the sponsors, foremost PharmaMar, of course, but also Implantcast, Novartis, and Bayer, who make this possible and also support us for next year. I think this is very good, and I think we have also gained today a lot of input how to improve also for next year. Having said this, the next webinar is scheduled for November 4th. Axel will present his summary of ESMO and ASCO, and I think this will be very exciting. Please join us again. It will be a great experience again. As I mentioned in the beginning, there's an opportunity to join the forum.sarcoma.academy. You can see there the cases which were presented today. You can also share your questions so that we can have an ongoing discussion also after the end of the webinar. With this, I would like to thank you everyone, all the audience, to stay with us. You hopefully could learn also with us. And if you have any suggestions for improvement, please let us know. It will be a pleasure to address these issues. Then I thank you very much. Have a great evening. Have a great end of the week. Bye. See you next time.
Goodbye.
Thank you.
Thank you.
Bye.
Bye.
Thanks.
Bye, everybody.
Bye.